Hello, my name is William Osai. I'm a family nurse practitioner. I was trained in general family practice. However, I've practiced in medical oncology for over 20 years. My talk today is going to be on prostate cancer overview. The objectives of this talk are to define prostate cancer, discuss the epidemiology of prostate cancer, enumerate the risk factors of prostate cancer, discuss the screening method of prostate cancer. Discuss the diagnosis and staging for prostate cancer, and finally, treatment of prostate cancer and the related side effects. To begin, a brief anatomy of the prostate. The prostate is a part of the male genitourinary system. It is located below the bladder, surrounding the urethra. At maturity, the prostate is about 30 to 40 grams. It reaches maturity stage between the ages of 10 to 14 years. The prostate may enlarge as men get older and cause urination problem. Prostate has 4 zones: the anterior fibromuscular zone, the central zone, the peripheral zone, which contains 75% of the glandular tissue, and the periprostatic zone. What are the functions of the prostate? The prostate produces the prostatic fluid, which forms part of the semen. The function is to nourish and protect the sperm. The prostate helps in closing the urethra during ejaculation to prevent sperm from entering the bladder. The prostate also propels the seminal fluid into the urethra during the contractions that accompanies ejaculation. What causes prostate cancer, or what are the etiologies of prostate cancer? These factors have been associated with prostate cancer, including age, genetic mutation, inflammation, and carcinogens. Singly or in combination, these factors influence the function of the prostate cancer through a variety of mechanisms that eventually results in the formation of prostate cancer. As an illustration, normal prostate cells are orderly arranged and undergo programmed differentiation controlled by a regulatory mechanism. At the end of their life, the cells undergo a programmed cell death. In malignancy, these cells become disorganized for a variety of reasons, including the ones mentioned earlier, and they are able to overcome the programmed cell death, and they grow uncontrollably and metastasize, meaning they spread to other parts of the body. How often, or what are the incidence of prostate cancer? In 2021, there were an estimated 248,530 new cases of prostate cancer, and there were 34,130 deaths. What are the risk factors for prostate cancer? Strongly associated risk factors include age, family history, race, environment/geography, exposure to environmental carcinogen, insufficient intake of fruits and vegetables, and obesity. Less strongly associated factors include diabetes, infection, inflammation, vitamin C and D deficiencies. I will discuss some of these factors in detail in the next few slides. In terms of geography, it appears that depending on what part of the world you live in, your risk for prostate cancer is higher. For example, in Northern Europe and Western Europe, the risk is higher than, for example, compared to men in Western Africa and South Central Asia. Age is a risk factor, as you can see here. Men between age 65 and 74 have a higher rate of prostate cancer compared to men who are in the 40s. The median age for diagnosis of prostate cancer is 67. Correlated with that, because it's reasonable to expect that since more men are diagnosed at older age, more men at these older ages will die of prostate cancer as well. Median age at death of prostate cancer patients is 80. Race is a risk factor, as you can see here. Prostate cancer is more common in blacks at the rate of 175.8 per 1,000 compared to 90.9 in Hispanic males and 104.1 in Caucasians or white males. Same applies to death from prostate cancer. 37.4 per 100,000 Black males who have prostate cancer die from it, compared to 15.6 in Hispanics and 17.9 in Caucasians or white males. Family history is a risk factor of prostate cancer. Men that have a first-degree relative, brother or father, have a higher incidence of prostate cancer. Specifically, if a man has a brother who has prostate cancer, the relative risk is 3.14 and 2.35 if they have a father who had prostate cancer. If there are two or more relatives with prostate cancer, the relative risk is 4.39. Genetics also plays a role in prostate cancer development. Men who have a mutation in the BRCA2 gene have a higher incidence of prostate cancer, develop prostate cancer at a younger age, and have clinically significant tumors. Therefore, men with confirmed BRCA2 mutation should be screened more intensely than the average male. Tobacco use has been associated with prostate cancer as well. According to this study here by Hocharek and Haddock, shows that men who smoked the heaviest have a 24 to 30% greater risk of death from prostate cancer than non-smokers. The VA has recognized Agent Orange as a risk factor in men who were exposed to this agent during the Vietnam War. Agent Orange was associated with a 52% increase in overall risk of prostate cancer detection and a 75% increased risk in high-grade prostate cancer in these men. Also, these men have a 2.1-fold increase in Gleason 8 or higher prostate cancer. Inflammation has been associated with prostate cancer as well. In a meta-analysis by Dennis and Lynch, prostatitis was shown to increase the risk for prostate cancer with an odds ratio of 1.6. And also an odds ratio of 1.8, increased relative risk among men with a history of syphilis and gonorrhea. Also, in a meta-analysis, Dennis and Dawson reported that there's elevated relative risk of prostate cancer among men with a history of sexually transmitted infections. For syphilis, relative risk rate is 2.3, 95% confidence interval, 1.3 to 3.9. Risk of prostate cancer is also associated with increasing frequency of sexual activity. With 1.2 relative risk for an increase of 3 times per week. Furthermore, increasing number of sexual partners is also associated with prostate cancer, with a relative risk of 1.2 for an increased risk of 20 partners, 95% confident interval of 1.1 to 1.3. Diet and obesity has been associated with prostate cancer, specifically in terms of the type of fat that is ingested, saturated fat versus unsaturated fat. In that, saturated fat is associated with the increased risk of prostate cancer. The Western diet has also been associated with prostate cancer with the suggestion that intake of processed foods and high glycemic index foods might contribute to to the increased risk of prostate cancer. For example, Japanese Americans have a higher incidence of prostate cancer compared to Japanese men who reside in Japan. So how do you detect prostate cancer? Prostate cancer is detected by screening with two activities: the prostate-specific antigen, PSA, and the digital rectal exam. The PSA is a blood test that is used to detect prostate cancer, and digital rectal exam is an exam performed by a physician, where the physician uses his finger to feel the prostate for any abnormality. So, in brief, the PSA is produced in the prostate, where it's typically contained and very limited amount gets into the bloodstream because of the integrity of the prostate organ. However, when there's disruption in the prostate architecture, a lot more of the PSA seeps into the bloodstream and is detected. And the higher the PSA, the more likely that the patient has inflammation or prostate cancer. As mentioned earlier, PSA is measured in the serum. Normal PSA is generally less than 4. However, this is not a 100%. Does not rule out prostate cancer 100% of the time, because some men with PSA of less than 4 can have prostate cancer. Also, by experience, it has been observed that PSAs might vary depending on the race and age of the patient. Therefore, several recommended ranges are shown here. For men between the age of 40 and 49, in Asian Americans, the recommended range is 0 to 2. For African Americans, 0 to 2 also. For whites, 0 to 2.5. For older men, 60 to 69, the values are shown here, and also for men, 70 to 79. What are the current recommendations for screening for prostate cancer? The American Urologic Association does not recommend prostate cancer screening for men under 40. They also don't recommend routine screening for men between 40 and 54 unless they have a family history of prostate cancer or are African American race because of the higher incidence in that group. For men between 55 and 69, prostate cancer screening is recommended. However, this has to be a shared decision between the patient and the physician. For men over 70 or maybe 75, no routine screening is recommended. Also, for men with a life expectancy of less than 10 to 15 years, screening is not recommended. Now, when men have elevated PSA or have a rising PSA above the range for the age or race of that particular patient, or they have symptoms such as erectile dysfunction, urinary frequency, a biopsy is indicated to rule out prostate cancer. Also, men who have an abnormal digital rectal exam should undergo a prostate biopsy. Biopsy is done as a background. The digital rectal exam, the physician will introduce his finger into the rectum and palpate the prostate to feel for any abnormal hardness, change in the configuration of the prostate, or irregularity in the surface of the prostate. As stated earlier, PSA ranges between 0 to 4 is considered normal. Indications for prostate cancer biopsy, as stated earlier, is rising PSA or change in the PSA from year to year. abnormal digital rectal exam. And then for diagnosis, a biopsy of the prostate is performed, where the physician introduces a probe through the rectum and and with the aid of a needle, gets tissue from the prostate in a systematic fashion. Typically 12 cores are obtained, and this is sent to the pathologist for review, who will help, the pathologist will help quantify and determine the grade of the disease. The procedure is typically well tolerated by patients. The potential side effects include infection. In rare cases, sepsis, where the infection spreads into the bloodstream. When the pathologist reviews the biopsy specimens, they will classify the cancer according to how much cancer there is and what grade. The grades are usually between 6 and 10. The lower the grade, the less aggressive the tumor is. And the higher the amount of cancer in the prostate, the more likely it is for the patient to require treatment. So the grades are shown in the next few slides. I will not go into details of it, but the take home is that the higher the grade of the cancer and the more involved with tumor the prostate is, the more likely the patient is going to require treatment, and the more intense the treatment is. For patients that have low grade and low volume disease, active surveillance is an indication. Active surveillance is the process where treatment is not given immediately, and the patient is followed over time with PSA check and periodic biopsies. For men that require immediate treatment, radical prostatectomy, where the prostate is removed, is an indication. It's indicated. Radiation therapy, which includes either external beam radiation therapy or brachytherapy, where radiation seeds are implanted in the prostate. In men who have advanced disease, hormone therapy and radiation combination is indicated. And those with metastatic disease, hormone therapy only, or in addition to chemotherapy, are indicated in these men who may have incurable disease. After treatment, men will develop symptoms depending on the kind of treatment they receive. For men who receive the hormone therapy, fatigue and weakness is a common side effect. This also applies to men who have radiation and surgery. Pain is an added side effect of radiation, included added side effect to radiation. Also, in men who had surgery, pain and weakness is also a part of the potential side effect. For men that have radiation, they may develop fecal urgency and incontinence. This is rare in these days, where because of the increased ability of targeting the prostate and avoiding unintended radiation to surrounding tissues like the bladder and the rectum. Again, proctitis, irritation to the rectum or anal area, is also less likely these days with better targeting of radiation treatment. For men who receive hormone therapy, there's the risk of developing bone loss, metabolic syndrome that includes diabetes and obesity, hot flashes, and weight gain and obesity. Regardless of the kind of treatment that men received, psychosocial disturbance might occur, which includes anxiety and depression. Sexual dysfunction is pretty common among men who undergo prostate cancer treatment, regardless of what kind of treatment they received. In terms of bladder control, men who underwent radiation therapy and surgery can develop incontinence, urethral stricture, which might affect the ability to urinate or empty the bladder, as well as urgency and frequency. There are remedies for these potential side effects that patients can discuss with their clinicians. In summary, prostate cancer is common in men, especially at older age. The way to screen for prostate cancer is with a PSA blood test and digital rectal exam, where the physician uses his or her finger to palpate the prostate for abnormality. The prostate cancer is diagnosed with the aid of a biopsy, where the physician introduces a probe through the rectum to get prostate tissue for evaluation by the pathologist. The treatment for prostate cancer depends on the grade and the amount of cancer in the prostate. Treatment methods include active surveillance, surgery, radiation, hormone therapy, and chemotherapy. Side effects of prostate cancer treatment are numerous, but they are manageable. There are several resources out there for patients who have a need to get reputable information about prostate cancer. The American Cancer Society, the National Cancer Institute, the Office of Cancer Survivorship, and the Prostate Cancer Institute are all reputable organizations with good information at their websites. MD Anderson Cancer Center, if you live in the Houston area, or has a lot of information regarding the management of prostate cancer, as well as the National Comprehensive Cancer Network. Thank you for participating in this program.